Welcome everyone. I'm Dr. Amanda Rostov, Head of Research at Autistica. I'm delighted to introduce our first keynote speaker, Professor Sven Bölte, who's going to speak about how we can ensure that we support every autistic person from day one. Sven is Professor of Child and Adolescent Psychiatric Science at the Karolinska Institutet in Stockholm, in Sweden. In the last 10 years, in partnership with the World Health Organization, ICF Research, and hundreds of researchers and stakeholders, he's adapted the International Classification of Functioning Disability and Health, the ICF, embracing this holistic approach to supporting neurodivergent individuals. Sven is a partner of Autistica to develop and trial the implementation of evidence-based tools, such as the ICF, that can support the strengths and needs of autistic people. In this talk, Sven will explain how we can use the ICF as a basis for support assessments for autistic people in different contexts, including educational, clinical, and social care. Sven is convinced that using the ICF to evaluate a person's strengths and challenges and their environmental facilitators and barriers will initiate an urgently needed societal system shift towards a holistic understanding of neurodivergent people in their unique world that will guide better services, support, communication, and solutions. Over to Sven.
Hello, welcome everyone. It's great to have you. It's a privilege. Many thanks to Autistica for inviting me to their research festival, and apologies that I cannot be with you today live, because in Sweden, kind of the July is our summer month where it's warm and bright, and that's where we take holidays. So this is obviously a recorded lecture. Today I would like to talk to you about my thoughts and also my research and development work in the area of autism personalized support assessment. And I'm Sven Bölte. I'm a professor at the Karolinska Institute in Stockholm, and I'm heading a center for neurodevelopmental conditions and titled Kind. And if you're interested to follow our work and my work, you see we are also, of course, on social media. I would like to start with a disclosure. It's good scientific practice to tell you that I'm, aside of my academic work, also interact with the industry when it's needed. So you can see what I'm doing here on this slide. And it's, I guess, most important for you to know for this talk that I will talk in the end about an online platform for making personalized assessment. And we are doing this together with a startup company called Neurosupport Solutions. And I'm also part of this one, mostly because I would like to have control and protect the research and development that we're actually doing. When the researchers talk, I heard that many times, people often say that they have a little bit hard time sometimes to follow what they say. And when they open their mouth, it goes like la, 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 and blah, blah, blah. And even though people may experience that's probably something interesting or probably something important, maybe they cannot follow all of the time. So I've tried to make this as keep it simple as much as possible and guide you through this program. So the roadmap for today is first to tell you what this talk is about really. I will then present the conclusions so that you already know somehow where I'm going to. I will then talk about the background, then about the ICF, the International Classification of Functioning, which is the system that I think we can and should use for personalized assessment in autism. I will then try to make a case why the ICF is good, why it's maybe new and better than other approaches that we use at the moment. I will then talk about if this is really going to happen, or is this just another story that a researcher is telling you, or is there really evidence or kind of good is it likely that this actually will be part of clinical practice one day? And it will tell you where we are with the work that we do in this area and what's happening next. So first of all, what is this about? So this is about the ICF, as I said, the International Classification of Functioning, Disability and Health. It's one of the systems that the World Health Organization has created. And I would like to convince you during this talk that this is an excellent system to use as a basis for personalized assessment of strengths and weaknesses, and of environmental barriers and facilitators in the lives of autistic individuals. And of course, also other people who have some kind of disabilities to deal with. And I would especially also make the case that I think the ICF is a good system to really also to get system change in this area, a system change in healthcare, in education, and in the social support systems. And I would like to convince you that it is likely that we can do it with the ICF, while we maybe other times have a hard time to get our voice heard. So my three conclusions to start with are that I'm convinced, and I have been for a long time now, that we have a certain over-focus on diagnosis, both in the assessment and treatment in the area of autism. So, and this maybe has hampered our thinking and action, not only by researchers and clinicians, but also kind of in the whole system that we use when we think about clinical care, education, and social services. And I think that we need to, well, in the assessment and also when we choose treatment targets, we need to have a shift away from diagnosis, more into the evaluation of individual strength, individual weaknesses, individual goals, and also have a larger focus on the impact of the environment on individuals' life, and need to address more how all of this affects an individual's quality of life, because quality of life, that's in the end what really matters for all people. And as I told you before, I think that the ICF, the International Classification of Functioning, Disability and Health by the WHO, gives us really a good tool to get going a paradigm shift in practice, not only kind of in a clinical setting, but kind of really in the whole of society. Good. Let's talk a little bit about the background. So I have I'm coming here with a citation from a famous philosopher and psychologist from the 19th century, William James, and he said, "Well, the deepest principle in human nature is the craving to be appreciated," and I think it's a wise word. I think on whatever level and which individual that we can think of, everyone would like to be seen and understood, and also understood in all its facets and details. And when looking at the whole the whole picture. Who am I, and in what kind of situation am I? So I think that's important for all people, and it's particularly also important for people who have challenges. I think especially for those, this is a very important quote, because often people feel not understood and not seen, and maybe also reduced to their challenges, where we do not see all the other things that also can impact. And during my clinical and research career, I've often seen that people claim that they have a holistic approach, and that they see the whole picture. But then later maybe you get the impression, well, that's maybe not true. They maybe have, well, a certain theory or a certain approach that they follow, and maybe the person kind of in all its different aspects gets kind of lost during the process. If you look at, for instance, the core values and the missions and the documents that most of the organizations that we talk about here, so everything from pediatrics and child psychiatry and adult psychiatry and a lot of the social services, and even preschools and schools and university, when we look at their documents, you will probably very often see that they claim that they have a holistic view, and that they have core values where they want to appreciate the person as an individual, and really focus on their needs, and their way of being unique. So, for instance, I took this here from an organization that works under the NHS, and where you can see in the core values that, of course, we are providing personal and holistic care, and we want to do service which puts the individual at the heart of everything that is done, and also that the needs and the specificities of a certain individual, that those should always be met. And I'm quite sure that really that's what these organizations also always want to achieve, and even that most of the people who work there wants to achieve this. But somehow, often other things come in the way, and also need to look at and prioritize. For instance, how much resources they have and their budget, or maybe if there's sufficient staff, or is there maybe a lot of new staff coming in and out, or they have problems in finding qualified people. So somehow there come many other things first, and again these values and these targets, and this holistic view is a little bit lost somehow. And then we look at, and I think to a certain degree there are also kind of systemic aspects that are a little bit in the way for being more personalized, and for looking more at the individual needs. And that's for instance how we have built and constructed healthcare, for instance, which is often built around diagnostic manuals. And there's really nothing wrong with diagnostic manuals. They have helped really a lot for having effective systems for documentation, for research, for communication. So it's not that I'm saying that there's no value in diagnostic manuals, but I also think that many people, especially in the area of neurodevelopmental conditions, think we have reached certain limit where they are not informative enough to achieve the aims we have, and they're particularly not very informative always if you want to get a better idea of a specific individual, because the tradition of these manuals is that they apply a biomedical model almost exclusively, and that this biomedical model more or less says, well, there's an issue with a certain individual, and the issue is kind of more or less some kind of disease that need to be fixed, and the fixing needs to be done more or less kind of based on a certain cure and based on some kind of form of etiology. And those manuals, they classify diagnoses, and then we use those diagnoses on individuals. And what we do in this process is that a unique individual is kind of allocated to a group. And during that process, there's a certain risk also that the individual nature of a person and all that's very specific, and also that's everything that's very, well, can say close to everyday life, that this somehow is a little bit lost on the way. So we have made experience that diagnostic manuals, we use them, and they have made a good value, but they do not really help us, especially for this holistic view of a person. Then in recent years, especially in the last decade, there have also been kind of another approach to, especially in neurodevelopmental conditions, and that's the neurodiversity paradigm that probably you're all aware of. And I would say kind of my interpretation of neurodiversity paradigm is that it's more or less a kind of a social responsibility model of autism and other neurodevelopmental conditions, and that there is that what it mostly says is well, society also has responsibility. Kind of the environment has a responsibility when it comes to how well people with neurodevelopmental disability can live their lives. And it also says, well, we are not talking, or kind of rarely talking, about anything that is disease. We are mostly talking about otherness, people being different but not sick. And it also says, well, people may have challenges, but they may also have strength. And that cure is something that we cannot achieve, and that we do not want to achieve, but it's mostly about acceptance and support. So, and I would say, well, in my experience is, well, we both need the kind of biomedical aspect and the psychosocial aspect to give a good idea of a person. I have seen that in areas where there's a biomedical tradition, the psychosocial aspect is often completely lost. And when there are a lot of psychosocial issues, then people are not very good in handling those. And when you are in, for instance, in social services where there is no tradition and no competence of the biomedical area, then this dimension also often is lost. And this can also lead to an incomplete understanding and care. So I'm quite convinced that we need kind of both models in certain individuals. Sometimes maybe one of the models is enough, but often it's quite good that we have the full picture, the biomedical one and the social one. And these two models have been used quite kind of opposed to each other, while I would say they probably rather complementary. But there has not been a good way of combining those, kind of bringing them together in a meaningful way. There have often been kind of more polarization of positions in the discussion. And what I'm convinced of is that the ICF, the International Classification of Functioning, Disability and Health, is a system that can harmonize and can take into account both of these paradigms and models and traditions. And I've written, together with other people, also an article about this, how the ICF can reconcile things that people often think are irreconcilable. If you want to read more about this, but I will tell you in the following why I think this is the case. To do this, I first need to tell you what I think, or kind of what functioning is. And I understood or understand that the word functioning is a word that's not that it does not sound very well in English, or is understood as a kind of a negatively connoted word in the UK. But let me try to explain how it's understood in the ICF. In the ICF, functioning is kind of the resulting abilities and disabilities that a person is kind of showing. And these are understood as something that emerges in an interaction between an individual and a specific environment. So it's not only individual, it's not only in the environment, it's kind of how the individual characteristics and the specific environment, how they kind of act and interplay together. So you can say it's kind of functioning as a person in its own world. And it's so you understand that functioning is a quite important dimension when we look at, for instance, autism, because kind of functioning is more what a person kind of can do or could do or actually is doing in a certain environment. It's a very important dimension in the way that people live today in modern societies. And then closely related to functioning often is the experience quality of life. So how am I feeling? How am I really doing? Am I enjoying life? And I'm enjoying kind of my life as such, and in which areas? And these are the two major kind of dimension, of course, for an individual. While we often in the clinical area, we are more kind of mostly looking at the tip of the iceberg. So we are trying to rather put some kind of label on a situation. We're trying to understand a complex situation rather by condensing it to a label, which in this case is called autism. But in the end, to understand an individual and even to make support possible, we need to look especially also on functioning and quality of life. And these two dimensions you do not find a lot of in the diagnostic manuals. You find a little bit about functioning, but on a very global level, not on an individual one. And you will find almost anything about quality of life. So I also already told you what functioning is. So what is quality of life then? So quality of life is how an individual experience life satisfaction, well-being, and happiness. And we sometimes say also health-related quality of life. And we say this always when we look at quality of life in face of a diagnosis or a condition being present. So, and importantly, when we talk later on about functioning more and the ICF system, is that there's quite some good evidence that a lot of these functioning aspects, that they actually predict also quality of life. Of course, you can have people who are kind of low functioning and have very good quality of life. Or you can have people who are, for instance, have a very kind of mild autism phenotype and are very high functioning and still have a very low quality of life. So you can find all of these combinations, but typically people who are in their own kind of characteristics, and especially in the interaction with the environment, kind of low functioning, they often also have kind of low quality of life. And we know this is just some research here, because I think it's important to give you examples that we know, for instance, certain cognitive functions, neuropsychological functions. So the way that you kind of think and act, for instance, in terms of self-regulation. So if you are skilled, and if you have the possibility to control yourself, regulate your impulses, your thoughts, and so forth, that this is a quite strong predictor of quality of life, for instance, in autism. Or another issue, for instance, sleep quality is also a function that used to determine a lot how people experience their quality of life. When we look at what research so far has addressed, for instance, when in intervention studies or support studies, then surprisingly, this is not very kind of consistent with what actually people with their own diagnosis and also their relatives would like intervention and support to focus on. So when we look here, these are two studies, one by Helen McConaughey, where people have looked what are the preferred intervention targets by parents. Now you can, for instance, see here down to the left that kind of highest ranked is that parents just mostly want to have that their children are feeling well, that they feel happy. And then there also come other things later, like experience stress or kind of mental health issues. So a lot is about really, they just want their offsprings to feel good. And we have done in the course of a support program that's called Transition, where we try to support young people, young autistic people or people diagnosed with ADHD, in kind of helping them to get going with their own life and independent lives. And where we ask them kind of what are your kind of main goals? What do you want to achieve? Most of them say, well, I would like to feel better. I would like to improve both my mental and somatic health. So it's a lot about quality of life issues that people really want to see addressed. And as I said, a lot of these quality of life issues are also closely connected to what I call functioning, or how functioning is understood in the ICF system. But surprisingly, when we look at what research has focused on trying to change or trying to improve when support or some kind of treatment is offered, you can see that the vast majority of the research so far has looked in how far the support or the intervention can reduce the autistic symptoms. So this is absolutely not in line with the preferred intervention goals by autistic people themselves and their parents. And you can see that aspects of functioning, for instance, adaptive functioning, cognitive functioning, or even far more or less quality of life is extremely rarely or has extremely rarely been a primary target of support or intervention. So that is really something that we need to address. And I'm also seeing that this is changing quite a lot, that people do not think anymore that we need to reduce autistic symptoms, but that we instead need to try and increase that people achieve their goals, their individual goals, and that they get a better quality of life. So let me talk about the ICF then. So as I said, again, ICF, that stands for International Classification of Functioning, Disability and Health. And there's also a child and youth version, but the child and youth version includes all of the information that is in the ICF version that is for adults. And the ICF is a system where we try to register and try to evaluate individual from the perspective of disability and ability. And we take into account here by we look at the body functions of a person, we look at the body structures of a person, and that would be more the biomedical part. And then we look at the activities, what a person actually is doing. We look at participation, so how well a person is also kind of being kind of included or kind of is integrating itself into society. Then we have the huge area of environmental factors. So which factors in the environment are hindering a person or facilitating that a person can reach a higher level of functioning. And the last area is the one of personal factors. So are there any kind of things that are not necessarily part of a certain condition, but more related to the person as such, like lifestyle, for instance, or a person's kind of biological sex that can matter in different societies. For instance, it can in many countries still it is unfortunately a huge advantage of being female. So you have a lot of things in here that can affect functioning, but that are not necessarily related to a certain condition, but still affecting your functioning. So it's really trying, the ICF is really trying to get a holistic grip of to get an overview, to inventorize what are the person's strengths and challenges, and what in the environment can we find that either hinders or facilitates that a person can functioning well or better. And the ICF is one system in a family of manuals that the WHO is working on. The one major task of the WHO is trying to structure and to systemize everything around health and well-being worldwide. And the most used classification is the ICD, which is the International Classification of Diseases, where there's also a chapter about neurodevelopmental conditions. And that's focusing on the biomedical model. And the ICF is newer than the ICD. The ICD is, I think, about 80 or 90 years old. And you can see it's the 11th edition that has just been published in the beginning of 2022. And the ICF came out around year 2000, 2001. So you think it's rather new, and it's actually still in its first version. So, but it's increasingly used also, especially in clinical services, especially in the rehabilitation area, while the ICD is used all over clinical care all over the world. The philosophy of the ICF system is that you have those different areas that I talked about. So the body functions and structures, which is more the biomedical one. You have the activities, you have the participation, and you have the environmental and personal factors. And the idea is that they all interact with each other. They're not kind of living their own lives. The different aspects, they of course have an interaction. It's also being ideologically or kind of even ideologically neutral. So there's not a lot of theory and assumptions in that model. It's more really trying to observe and understand in each individual. There's also not, the model is not saying that anything is more important than anything else. So mental, physical, and social aspects for functioning are kind of valued equally. It's not only talking about disability, but also about the abilities of people. And it's very important in the ICF is the lived experience of a person. So it's very often also the person can make a quite important point of saying, well, this is how I experience my functioning. And I think if this and this and this could be changed, then I think I could do better. So the individual lived experience is quite important for the ICF. The ICF assesses as I said, kind of areas quite broadly. So you can see here in this table what is part of the body functions, for instance. We have all of the mental functions. They're, of course, quite important. You have the sensory issues and pain. You have things around language, but also the digestive system and the hormonal system and others. You have the body structures with anything about anatomy is part of. Then you have a huge section about the activities, what a person actually is doing, not only what he or she is kind of capable of, but actually doing. Everything from communication, mobility, self-care, and so forth. And then you have the last, also very comprehensive section about the environmental factors. How are products and technology affecting a person? How are attitudes affecting a person? How are policies and systems and the availability of care, etc., affecting a person? So it's a very comprehensive system. There are also then subcategories and sub-items. So in total, there are almost 1,700 different aspects that you can use to evaluate the functioning of a person. So it's very broad. Okay, I hope that you got the point. So now I would like to tell you kind of what is good then, or what is better with the ICF than with the other things that we actually do at the moment. I guess one thing is really the core for me also is the ICF is about individuals and it's really trying to get the whole picture of a person. So it really embraces pluralistic view of a person and trying to understand the person in its individual context. And we do not find this, for instance, in a diagnostic manual, where it's more trying to get an idea how we can kind of label the totality of the dominating, maybe behavioral kind of alterations of a person. It also enables, because we look, it enables positive psychology. And that means it can also show the strength of a person, and it can also show where kind of in the person or where in the environment are the opportunities. So where are the things that we can take advantage of? So it's not only trying to look at the whatever deficits, but it's also trying to give you a good idea of all the opportunities. And using, for instance, a strength-based approach, an opportunities-based approach, trying to increase what's good, trying to increase what's working, rather than only trying to reduce what is not working or only addressing what is not working. We can equally also address and try to kind of increase actually the good things that are working out. The idea is also that the ICF should be something that is usable and shareable across different disciplines and also stakeholders. So the idea is it should not be kind of a language and a system just for people who, for a certain group of experts. But the idea is the ICF should be something that we can communicate around across disciplines and also make it easier to communicate with lots of different stakeholders. As I said, when I talked about positive psychology, we can also take into account the strength in autism, and we know they are. Like all individuals, autistic people have strength, and it's important also to try to see where they are and use them, both for support, but also for kind of giving a person, an autistic person, a good sense of self. Something that is also important, for instance, for authorities is that the ICF can be quite effective for administration. There's a lot of information today that is only kind of in written word and is not condensed using codes. So with the ICF, we can lot more effective. We can condense a lot of information into standardized codings and standardized information, which could make administration and also registry analysis and statistics far more available and informative. And as I said, it's also having a strong focus on the environment. And this is, I'm sorry, this is a little bit of Swedish language for you, but these are statistics that the Autism and Asperger's Society and Society Attention in Stockholm have carried out around school absenteeism. And about 300 families, they completed this survey. And what you can see here is the given reasons from their perspective for the school absenteeism of their children or themselves. And you can see that this was, of course, a multiple choice questionnaire. So you could use different answering options, but you can see here that a lot of these things that were said have actually not so much to do with the individual, but rather with the environment. For instance, bullying going on, or teachers being not compliant, or that the learning environment was insufficient, or that kind of really things that we would think are really able to address in a high income country and a welfare country like Sweden, they still are important. For instance, that the way to school was too complicated, or that there was a lunch situation in the school, that it was just too stressful to go to. So we can see even in highly developed countries, there are a lot of things that we can actually do to make lives a lot better for autistic people that have nothing to do with the individuals and that are really the responsibility of the environment. And that is things that we can make visible in the ICF and that we cannot make visible so easy using other systems. This is another example for the environment. I don't know how it is in the UK, but in Sweden, there is a development to make the built environment in the schools a lot more kind of free and open and unstructured. When new schools are built, they're often built with lots of direct light and glass and more kind of an architect's dream. Could be an autistic pupil's nightmare. And these things happening, and if they happen, it's also something that we, in an individual case, can highlight when we make assessments that these things actually play in largely maybe in the situation of individual children. Well, then you may wonder, will this really happen? Is this just an idea put forward by me? And I'm actually, or kind of, will this really make a difference in the future? And I would say, well, at least it has a lot better chance than a lot of other things that people maybe have tried, because I mean the ICF is an official manual by the WHO, and most authorities, there are national authorities who are using and the WHO instruments and have made them a primary standard. And in many countries, the ICF actually already is established as something that people should do or must do in different areas. It's just not, it's just the process is a little bit rigid, and there need to be some fuel into the system to really make this more attractive and to use. And that's exactly what we are trying to achieve with our work. There are also on national, as I said, on the national level, also different documents and guidelines and decisions taken to implement the ICF. For instance, in Australia, the guidelines for autism assessment, they have a large focus on the ICF. In Sweden, our National Board of Health and Welfare say since 2019, actually, when you make disability assessments, you should use the ICF as a basis. There's also a jurisdiction in Germany, and when you look at the National Strategy for Autistic Children in the UK for 21 to 26, there's also a major point making those individualized strength assessments where the ICF could play a very important role. So where are we now in trying to make this happen, trying to implement the ICF? So when we started, there were some challenges. As I said, the ICF is quite new. It's quite comprehensive too. So it's not so easy to use right away. People experience it as very complex, as not very feasible. They have a bit of a problem with the language that is used. It's not yet kind of well known. A lot of people do not have sufficient training on it. There's also some skepticism around people who maybe have worked with only according to biomedical philosophy. Maybe they have a problem with opening up and also kind of trying to accept that they are that kind of more biopsychosocial thinking is something that we need to do. So the acceptance may be limited in some instances. And the most important thing from an administration or research or clinical point of view also is that the ICF does not have kind of a certain or direct link to certain diagnoses. That's because the philosophy of the ICF is not to be diagnosis focused, but individual focused. On the other hand, of course, it is important that you have some kind of link between the work, how you do it currently, and something new that you want to bring into the field. So this is what I have done together with many other people and the WHO and the center called the ICF Research Branch in Switzerland. We have tried to adapt the ICF to both autism and also to ADHD, trying to reduce the amount of codes to the ones that are most important for these diagnoses. And this process has taken quite a lot of time. We have done a quite huge series of studies trying to find out what the most important information is in autism and ADHD that we need to make a good but also doable, individualized, personalized assessment. And it's based on systematic literature review, where we look at kind of the research that is there. We have interviewed people with diagnosis, their relatives, personal assistants, interest organizations. We have asked international clinical experts, and we have also done examinations actually in the clinical department to find out what's the most important we need to think of when it comes to functioning within autism and also ADHD. Then when we had this selection of information, of codes called the core sets, then we have validated those. We have looked if they really do work. For instance, when you look at the school environment, or when you look at employment, or when you, for instance, look at the impact of COVID on people's life, do we have the information in those core sets that we need to make a good evaluation of a person or the situation? And most of this research has shown that the vast majority of the information that is relevant for certain contexts can actually be coded using those core sets. Of course, we're all individuals, and it cannot cover everything in each single individual. Then these need to be added. But it covers really broadly the most important aspects of functioning. So what we have done now is we have taken all of this research and evidence, and we have then kind of translated these core sets, so translated the selection of codes to describe functioning into an online platform to make those individual assessments of strengths and weaknesses and environment, to make this more effective, to make this more accessible, and to also make possible kind of standardized outputs, so that you get a good and nice overview of what are the individual weaknesses and strengths, and what are the major environmental barriers and facilitators. So this is available on an online platform, currently in Swedish and in English. And if you want to know more about this work, I have put some links here for you. I'm quite sure you can that we share this presentation with you, or you can also look at this presentation again. So here are links, both more on the ICF, but also on the platform and the core set development. What we are doing currently is we are evaluating this platform. We look if it's user-friendly, how it is experienced, what do people on the autistic spectrum think about it, what do parents think, what do clinicians think, what do teachers think, what do social workers think, to really get an idea, is this experienced as something valuable? Can it be done in current practice? What can we improve? So we're looking at the ecological validity. Is this really a thing that can be implemented broadly and nicely in different contexts where autistic people are living, or kind of where they encounter professional staff? Well, we want to do other things, of course, looking at the scientific properties of this instrument. We're going for other languages. We are doing German at the moment. There's a plan for Hebrew. There's a plan for Chinese and other languages. We want to do, of course, also a very easy, accessible version with a very, very easy read. We maybe want to have picture support. We maybe want to have something that people can have white noise in the background, if that maybe improves the way that how they can work on these questions. And we are planning then to make a final version and a large-scale study, also looking how these different functions really relate to the quality of life of people, to mental health aspects, and so. And I'm very happy that we're not only doing this in Sweden, but that Autistica is also interested in testing this system in the UK, and there has been a grant announcement that is out at the moment, trying to support ICF-based research and this platform in the UK. And we also have an ongoing collaboration with the Sheffield Autism Research Lab, mostly around the lab director, Dr. Megan Frith, where there's also an application to the NHS. So this is ongoing, and I'm really hoping that we can make good progress in Sweden and in the UK and elsewhere, and trying to find out how we can best implement the ICF in personalized autism assessment for maximizing support and understanding of autistic people. Of course, all of this is nothing that I do myself only. I would like to thank all the funders that you can see here: Vinnova, Formas Forte, Promobilia, Vetenskapsrådet, Trygg-Hansa, and Klaus Kruszinski. The steering committee that we have with international experts for autism and ADHD, all my co-workers, and then of course the many autistic people and their parents, and even clinicians and teachers who have contributed to the data collection and the research. Yeah, then I stop here. I hope you could follow my thoughts, and that it was a little bit inspirational for you, and that it reached the threshold for something that is that you can present at a research festival. I thank you so very much for your attention, and hope that you have a very nice remaining conference and other interesting talks. Thank you very much. Bye-bye.